Hello, welcome, and thanks for joining us to help choose home when care is needed. A podcast all about the benefits, value, and safety of receiving care and services in the one place that feels most comfortable, wherever it is that the person needing care calls home. I'm your host, Marilee Orsini, and I've been involved in healthcare at home since 1981. Before we meet today's guest, a brief thank you to our sponsors and partners, the National Association for Home Care and Hospice, Access, and Core Cubed. Today's episode is number 4 of Season 3, and our guest is Dr. Michael Fratkin. He is founder and CEO of Resolution Care. Dr. Fratkin has been a leader in a community hospital medical staff, a medical director of the local hospice, and he also offers primary care in a community clinic system in several counties in rural Northern California. I think you will agree with me after our podcast today that he truly is a transformative voice, and he advocates for improving the care experience for people who are acutely ill or facing the end of life. Please help me, won't you, in welcoming Dr. Fratkin to Help Choose Home. Michael, thank you so much for joining us today. And you are joining us from Northern California, correct?
That's right. Far, far Northern California. We're about 5 hours north of the Bay Area in a beautiful place full of redwood trees and blooming rhododendrons called Humboldt County.
And that sounds gorgeous. And would you please start me off by telling me about your business?
Well, the organization that we built in 2014 is called Resolution Care Network. And what we do is we take care of people, not patients. We take care of folks with serious illness, the people that are caring for them, in their home using a combination, well, it used to be a combination, but using telemedicine as a way of connecting a team of palliative care professionals with people and their families at home.
I did have the opportunity to listen to a TED Talk that you did, and this idea of changing how we end our life is something that it sounds like you've been passionate about.
Very passionate about. I noticed a long time ago, maybe when I was a kid, that the body that I'm wandering around in is not the whole story. The person that I am, the relationships that I have, the experiences that I accumulate, the ideas that I generate, those all have a lot to do with the nature of myself. And as a physical medicine trained physician, I realized that we were dealing with some of what people face when medical illness comes along the way, but we weren't dealing with the things that were most deeply important to me as a human being, as a man. And so my shift in attention from the medical to the human experience of navigating serious illness and even approaching death became more than a passion. It became the air that I breathe.
And it sounds like you have assembled quite a staff of people who hold similar interests to yours.
Oh my goodness, there are so many incredible nurses and social workers and chaplains and administrators that recognize they're humans first before they put on the hat of whatever role that they have. And so, I have had such amazing good luck in bringing together dedicated professionals that are incredible human beings as well. We have about 35 people that are co-working to create this organization.
But you're doing more than that, more than an organization. It seems like you are really wanting to have an impact on changing how people face serious illness and end of life.
Well, we want to join the best possible medical care, the best possible specialty care. If you've got cancer, the best possible oncology care. If you've got heart disease, the best possible cardiology care, with the best possible person-centered care. Those two things go hand in hand or hand in glove. They're concurrent and aligned in trying to create the best possible outcomes for people in terms of their cancer, but also in terms of their families, in terms of their quality of living, in terms of their lived experience navigating the crazy healthcare system. And we like taking care of people in their homes because that's where they're people. We package them up and put them into our clinical environments. They almost instantly become patients. We like taking care of people, not patients.
So during this crisis, our current COVID-19 pandemic, have you had patients that have the virus?
We, living in a rural environment, expect to see a surge of patients coming a little bit later than what has been experienced in the densely populated areas. So our work has been helping keep our folks safe, helping to support them by connecting them to community resources for food and companionship and the basic deliveries that are required, and to talk with them about what their preferences are and would be if they were to get sick. We've been able to go through our couple of hundred people under care and have very specific, very direct, very clear and compassionate conversations about what kind of care they might want if they were to develop a rapidly progressive respiratory illness suspected to be COVID-19. So the answer to the question is no, we haven't had any of our folks, knock wood, yet have to navigate coronavirus infection. We expect that, and we're prepared for it, but we haven't seen it yet in our community.
This is a consumer-focused podcast because in my decades of work in the care at home field, I find that most people don't understand that they can receive care at home and that it is a different experience. How would you recommend a consumer, because these people from all over the country listen to these podcasts, how would you recommend a consumer find care as you are providing in their local community or something similar?
We're a sort of special group, right? We're not for everybody. You know, people who are managing some basic chronic challenges, high blood pressure, high cholesterol, or trying to just stay well. They're not folks that need an organization, a team-based approach to bringing palliative care to them in their home. But in this moment, where telemedicine has been discovered as a mechanism to connect primary care, episodic care, urgent care to people, I think people need to be willing to not see themselves as patients and honestly to not see themselves as consumers, but to see themselves as the people they are, empowered to access healthcare exactly at the level and in the location that makes sense for them. So there's tons of things that people can gain value in their medical care that can be happening at home, whether it's simply dialing up for an acute problem and getting your primary care in that fashion to get your prescriptions refilled, to get your blood pressure monitored, but also to be seen as the person you are rather than as a patient or even as a consumer.
If someone finds themselves in a medical setting and is feeling very much like a patient and a number, how could they approach their practitioner to level that playing field and put them back into being a human being and not just a patient or a number?
That's a really, really great question. I mean, most often the things that make the biggest difference are to recognize that the people coming to serve you are also people and not their roles or jobs, and to engage them in understanding, to have them pause from their agenda, to remind them that what you're working on collaboratively is centered around outcomes that belong to you, and to sit them down and to attend to your lived experience of the illness, not just the illness itself. Bringing in family members to assist, doing more work out of your home. The wonderful phenomenon of seeing a person in their home via video conferencing is a very level playing field. That person is in their own place of comfort, and I'm in my own place of comfort. That's naturally leveling. And it turns out that people are less likely to think of that one thing they meant to ask you while I'm reaching for the doorknob or the door handle as I'm leaving the encounter. So I think that writing notes beforehand, taking lists if that's needed, bringing in people that care for you who might remember something you might forget, and then seeing the doctor, the nurse, the social worker, the whoever they are as the person that they are and engaging them in that way. I think those are all things that will help people feel more seen and heard and understood as people they are dealing with the medical problems they might have.
Now, your practice, is it a hospice practice or palliative care or a combination of both?
We are a palliative care program. We're freestanding and not associated with another hospice organization or a health system. We're a freestanding palliative care program that's building capacity to deliver the palliative care offering to people who are still getting cancer treatment or still getting treatment for their heart failure, still might want to be evaluated or seen in the hospital if they end up acutely ill. For folks that are ready for hospice care, who can acknowledge that they're in the very last part of their lives, we transition them very smoothly into the wonderful community hospice programs that are closest to them when it exists. Our program is so rurally based and distance virtual and networked in that there's actually a pretty substantial portion of the folks that we take care of who don't have access to a Medicare certified hospice program or even a home health program. So we do everything we can think of to support them in finishing their lives at home if that's what's most important to them, or finding the right setting for them and their families when the end begins to approach.
Would you please define palliative care for our listeners so they clearly understand what it is that you do?
Well, I'll define it in two ways. One is my way, and the other is this sort of very agreed upon formal way of doing it. The way that I define it for the people that we take care of is, number one, we don't take care of any people, any patients. We take care of people, and we do that with a team. Nurses, social workers, chaplains, community health workers, all working together in an integrated way to support their care and quality of life. Number two, we're very good at the management of symptoms, the things that people feel and the experiences that they have medically. We're good at treating pain and breathlessness, nausea, etc. And number three, we help people and their families to navigate what is sometimes a very complicated medical situation, but which is always a very challenging human situation because the people we take care of are seriously ill. So that's the way I like to say it. The way that the Center to Advance Palliative Care says it is that palliative care is a specialty for people and their families as they navigate complicated medical circumstances. It is available and valuable at any stage of serious illness. And it is an extra layer of support happening at the same time as people are getting the best possible medically centered care. I'm sure I left out something, but
the other thing that you have done is this, because you are in a remote situation, using telehealth. And before we came online, you and I briefly chatted about the fact that using technology was not so comfortable for people until most recently. Now I think everyone, their grandmother and their great-grandmother even has been on a Zoom meeting. So talk to me about how you are using telemedicine and how the positives and how it impacts the people that you serve.
Well, there's two really major directions to go to answer that question. Number one is to be able to take care of somebody in their home and to help them prevent the getting ready to go, the having a family member take time off from work to travel however many miles or through however much traffic, and then to deal with the parking, and then to getting into the clinic, and to schlepping through the front door, maybe in a wheelchair with a walker, and then getting past the front desk where they give you that damn clipboard again, and sitting down in a waiting room and wondering about the people that you're sitting next to and being coughed on and sneezed on. That's always been intimidating, but it's particularly so now to be, sitting there and waiting. I'm usually waiting past your appointment time while you're stuck with 10-year-old People magazines. All those experiences, and then being shuffled back into a windowless exam room while you're sitting there with the tongue depressors and a diagram of the sinuses on the wall, feeling anxious and out of place, and being a patient rather than a person. And then your doctor comes in probably 20, 30 minutes late. And when they talk to you, they're looking at their keyboard and their computer and have clearly their own agenda and their own stress as they're trying to fire their way through 2 or 3 people an hour under the stress and concerns of all their telephones and beepers and everything else going on. And then just as they get up to leave, you remember that one thing your daughter told you to remember to ask, or whatever it is that's really concerning to you. And they roll their eyes, but they deal with it, and then off they go. And then you reverse the direction and have to do all of that stuff to get back home, probably exhausted. And from a palliative care perspective, the irony of that is that the whole thing is designed to improve your quality of life. And that 4 or 6 hour adventure might be quite an investment for that gain. Turns out we had a lot of no-shows in the palliative care clinic. So all of that goes away. But the magic, once you get through getting people up and running, and that's sometimes is a challenge, but usually is not so hard to do. Once you get people all plugged in, what they get is a link and an email, and they click on the link, and you get a link in your email, and you click on the link, and poof, there you are. There I am. The playing field is level. I'm in my comfortable space that I've put together the way that makes me feel most comfortable, and you are too. And the possibility of discussing who and what we are and what's most important, what matters the most to the people we care for, happens remarkably more smoothly because there isn't all of that other stuff going on. In fact, it happens more smoothly by video conferencing than it does when I knock on the door and walk into their home and invade their home because of all the power structures and the authority of a doctor coming over to the house. They may have spent all morning, in spite of their serious illness, trying to clean up or hide certain elements of their home. They feel as if we've invaded their home. When I do it by video conferencing, everything I see, everything I learn happens by consent. If I want to know how they manage their medicines, I ask them to show me how they manage their medicines. So if they don't want to show me and they just want to tell me about it, or they want to hide it, they can do that. I have a thing where I like to look into people's refrigerators because I believe you can learn a lot about a person by what's in their refrigerator or what's not. Not just about nutrition, but about how well they're able to care for themselves. So it's like that. There's this initial kind of very pragmatic set of things that people don't have to do to get to me in my natural habitat, a clinic or a hospital. And then there's this other more subtle quality of kind of respect and leveling of the authority that allows us as a palliative care team to really understand not just what is the matter with you, but what matters to you.
Wow, that was really beautiful. That I've never heard using telemedicine described like that. That certainly does make sense, and is something that I guess as people are using technology more and more, perhaps this will enter into our medical community in greater usage, hopefully.
Oh, I think that the genie is out of the bottle, the toothpaste is out of the tube. Telemedicine is a part of the American healthcare system in probably the biggest revolution in healthcare delivery that any of us can remember. And it's been a pleasure and an exciting new frontier to learn how to use this technology to connect with people, not just for transactions, but for relationship building, trust building, and support provision for people that are already going through tough stuff. This is better than real life.
Well, Michael, I have a million things I want to ask you. We are out of time. Is there anything you would like to say, answer a question I didn't ask you, or something you would just like to say before we sign off?
Well, I'd just like to invite people to visit our website, resolutioncare.com, and to consider signing up for a little newsletter and to be connected to the work that we're doing. There's a lot of material there that's in the voice of the people we care for, some art, some video, and there's a lot of good information related to COVID-19 and advanced care planning and other stuff you might find interesting. And one of the things I've learned in building this organization is that it matters to tell the stories, the real stories, the human stories of the people that we are caring for. And we'd love to hear your stories as well. So I just invite people to join us.
Well, and I thank you for joining us today. And this is one of my favorite podcasts I've done. You have such a wonderful, gentle, human spirit about you. And I'm sure that's appreciated by your patients. And now you have a new fan. So thank you very much.
That makes me feel good, Marilyn. That makes me feel good. Thank you so much.
Thank you so much for listening today. And a special thanks to our sponsors and partners, the National Association for Home Care and Hospice, Access, and CoreCute. If you have not done so already, please subscribe to our podcast and take the time to leave a review on Apple Podcast. And we are now on Spotify, so you can find us in lots of different places. Like and follow us on social media, and join us, won't you, to spread the word and help choose home when care is needed.